Okay, so it's my honor and pleasure to welcome Dr. Gabriel Tobon for today's workshop speaker. Dr. Tobon is an assistant professor in the Department of Medical Microbiology, Immunology, and Cell Biology. He's a specialist in internal medicine and rheumatology with a PhD in immunorheumatology. He also founded the research group in rheumatology and autoimmunity, GIRAT. Dr. Tobon is going to share his experience and expertise in developing case-based resource sessions. So thank you, Dr. Tobon, for your time and willingness to lead today's session.
Thank you, Dr. Lee, and thank you for the invitation. So the idea today is I have no conflict of interest, and the idea today is to discuss a different strategy to make lectures. Because we usually, when we have to deliver content, we use the traditional lectures, but we can also use a slight modification, including clinical cases or questions to improve engagement and knowledge and participation of the students. So here, the idea is to be able to design and develop case-based learning sessions with specific outcomes, and also giving you strategies to incorporate this kind of resource sessions in the medical curriculum. So the idea here is to discuss the development and implementation of case-based resource sessions in the medical curriculum that can be used for year 1, year 2, and even for clinical practice. The agenda for today's presentation is definition, benefits to incorporate clinical cases, different strategies to make the implementation of the clinical cases and resource sessions, challenges, and finally, I have 4 different examples to incorporate this kind of lectures. So what is the definition? So if we think about the traditional lectures, we are right here. We have to deliver a content in a given time, for example, 1 or 2 hours. And we have a one-way communication with the students. We deliver the content, and sometimes the students are not very well engaged in traditional lectures, but lectures are still very important. Lectures have been replaced by some kind of strategies incorporating the students as a center, like the PBL, the tutor groups with the small discussions, with a clinical case and questions and problems. For today's presentation, the case-based resource sessions are in the middle, are between the traditional lectures and the small group discussion. We are still in a big room, the conference room with the students, but we can incorporate clinical cases and questions to modify the traditional lectures. And what are the main goals for this strategy? So there are many different benefits and goals, especially to engage learners. Because when we use the traditional lecture, sometimes the students are not learning, they are really tired, and 1 hour after the content, their retention is really low. The idea here is to engage learners, to improve knowledge, retention, but also application of the knowledge. And the idea here is to promote critical thinking and clinical reasoning. So we can make clinical cases, deliver the content, and then trying to incorporate this content in clinical reasoning and making decisions. So it's important because we use real-world application of medical concepts using one single case to incorporate or to improve active learning and participation during the session. So the benefits are multiple here, and probably the first one, and one of the most important, is student engagement. Is more interactive and stimulating in comparison to the traditional lectures. So the idea here is to deliver the content, making questions, and participation with the students. We can also enhance the clinical skills, developing critical thinking and practical skills with the real-world application of concepts they already have in the second year, for example, they already have the knowledge for basic sciences, biochemistry, genetics, anatomy. And here in second year, we are applying knowledge in pharmacology, pathology, to move to the clinical and real life scenarios. But for me, and probably the most important benefit for this kind of resource session is integrating different disciplines. So when we make a clinical case, we can integrate clinical presentation, diagnosis, pharmacology, pathology, biochemistry. So we can integrate different disciplines across the medical education. And finally, and one of the benefits is also to prepare the students for clinical rotations, applying basic sciences to the clinical decisions for clinical rotations. So knowing the benefits, here we have the 5 different steps to create case-based resource session. And these steps, and probably this is the most important part of the presentation, is the first one is trying to identify the learning objectives. So if you are planning to deliver a content in pharmacology or pathology or biochemistry, it's extremely important to know the learning objectives, the goals for the presentation. And then if you already know the goals, you can move to case selection and development. And we are going to discuss different strategies to create the case or to select the clinical presentation. The third step is structuring the session, then facilitating the session, presenting, making questions, managing the time, and finally, the feedback. So moving in every single step. The first one is identifying learning objectives. The first step is to define what the student should learn about the case. And as I mentioned before, it's extremely important to integrate pathophysiological aspects, physiology, biochemistry, clinical manifestations, and treatment. So probably it's a good strategy to build a case, or to implement a case, incorporating different disciplines. And another important step is align the cases with the curriculum goals, the clinical activities, and competencies. The second step is case selection and development. And here, I have to mention that some contents are more likely to fit in this model instead of different contents. For example, in pathology, we are delivering with Dr. S pathology, and it is very useful for this kind of resource session, for example, to cover renal pathology, when we have many different diseases that we can collect to make the differential. But it's the same for liver pathology, so big contents, or if you in pharmacology are covering antibiotics, so it's better or it's easier to cover when instead of small contents. You have to ensure that cases are realistic, diverse, and cover essential topics. And another important aspect is the complexity has to be extremely according to the level, knowledge level. If we are covering a case of leukemia or lymphoma, it has to be a simple case. If you are covering for fellows or residents, the case can be more complicated, like a patient with refractory diseases or complications of chemotherapy. But here, we have to be sure that we are covering the knowledge level. There are many different sources for cases or questions, like the patient records, faculty experiences, and different resources. Like, for example, in pathology, we use Robbins Review of Pathology. This resource has a lot of questions with very important points regarding the step 1. But also we can use the step 1 first aid to select the case or to modify or to make the draft for the case. We have to create a clear clinical scenario with patient history, symptoms, questions for discussion. The complexity, once again, it has to be according to the level of presentation with challenges. And that's extremely important. So if you're covering antibiotics, for example, you can modify the questions with challenges. What if the patient has an allergy to this antibiotic? What are you going to do if the patient is having an allergy or an adverse reaction? What is the second option? What if the patient is having an infection in the hospital, for example? So that kind of challenges can improve engagement, but at the same time, knowledge. And another important strategy for the structure is include key details like physical findings, laboratory tests, X-ray, or imaging in general to cover all the different disciplines. When you have the case, the third step is introduction to the case of question. Usually in the presentation, I use the clinical case or question as the first slide. So I present the question or the clinical case, and then we make the discussion and deliver the content. And finally, guiding to answer the questions. And another important point is to give the rationale for incorrect answer. So in that case, you can incorporate more ideas or more knowledge because you are not only giving the right answer, you are also giving why the different options are incorrect. The step 4 is facilitating the session. So what is the role of the faculty or facilitator? So the idea here is to incorporate participation so the students are engaged with questions, polls, prompts, or challenge to stimulate discussion. In pathology, we use Slido, for example, in our presentations to engage students with questions, but at the same time, the polls are very interesting. And we use different techniques like time management because we have the same time frame. We have 1 hour to cover or 2 hours to cover renal pathology, so we have to be at the same time and keep the group concentrated. We can use questions like this one to explore different perspectives. So after the clinical presentation, we can ask questions. What do you think about this findings? What is the main finding? What is the main issue here? What other information do we need? Or what is the differential? What do you think about the different options? What is not a patient with this pathology and what is having this different disease? So this type of questions can be challenging to the students. And finally, step 5 is to assessment, to assess and to have a feedback. First point is to provide explanations and summary using the same question or the same clinical case at the beginning, at the end with the incorrect answers, but also sometimes providing flowchart or concept maps to reinforce key learning points. And the feedback is used to guide the future learning. Regarding the implementation, here we have some of the best practices for implementing case-based resource session. The first one is creating a safe learning environment. That's extremely important. The students can be run, the students can participate with different questions, so it has to be a safe learning environment with open discussion and participation. Trying to incorporate different disciplines. For example, with fields like biochemistry, genetics, pharmacology. So if you have the opportunity in your clinical case to incorporate different elements from different fields, it's extremely important to remember that kind of content. We can also use technology like incorporating digital tools, online simulations, videos, multimedia cases, and also this technology is extremely important to adjust for different teaching and learning methods, like the visual learners using concept maps or auditory approaches. For example, in CRR, Dr. S has a session on cardiac murmurs. So the listening to cardiac murmurs is extremely important. At the same time, they are seeing the pathology, the different etiologies for any specific disease, but at the same time, they are hearing the murmurs. What are the challenges for this method and the solutions? And probably the most important is time. It takes time to prepare, to look for the clinical cases, to update the cases. But to solve this challenge, we can share clinical cases with the repository cases, or you can use the PBL case. You can use a modification of the PBL that the students are discussing that week, for example, to incorporate in your presentation, in your lecture, and to have the discussion. Training is also important, training and adaptation. So it's important for the faculty to deliver the content to be adapted to the multimedia or videos or different flow charts and concept maps. But we can train the faculty with this kind of workshops or facilitate the knowledge. And some students may prefer traditional lectures, and that's a challenge. But we can also introduce the students to the methods early in the curriculum, and we can provide explanations why it's important to participate. So here, this is the final part of the presentation. I'm going to share with you 4 different examples that I deliver in pathology with case-based resource sessions. So the first one is a single case with different diagnosis possibilities. For example, in renal pathology. So we are using the same clinical presentation with different possibilities due to the renal biopsy. The second example is one case with multiple questions. That is a different strategy. It's using just one single case with multiple questions at the same time. This is the example of type 2 diabetes. The third one is the example of viral hepatitis. It's just one single case with differential, but the serological findings are different. So here, I show to the students the main differences in the epidemiological aspects and serological findings. And the last one is an example of rheumatoid arthritis. It's just one case with the clinical presentation, but we can discuss the clinical presentation trying to have the differential or trying to rule out the different diagnoses. So I'm not going to enter into the details, the clinical or the pathological aspects, but this is the first example. This is the traditional lecture. Here we are covering renal pathology, especially in 2 different groups, nephritic and nephrotic syndrome. Here we are in the nephritic pathologies, and we have one specific type of rapidly progressive glomerulonephritis. Just for the presentation here, this type is characterized by crescents here in the renal pathology. But there are 3 different pathologies that can produce this kind of findings: a rapid decline in renal function and crescents in the renal biopsy. The 3 types are type 1, type 2, which is basically mediated by immune complex, and type 3, ANCA associated. So I deliver the content as usual with the main findings in the renal biopsy here, and then the type 1. But here, for example, we have the first difference between type 1, type 2, and type 3 is the immunofluorescence. So it's another important strategy trying to highlight the main differences between the diagnoses. So here, for example, we have a linear deposition in type 1. For type 2, that is mediated by immune complexes. We have a granular deposition because it's different. It's an immune complex that is circulating. And the third one, which is mediated by ANCA, is a post-immune. There is no immune complex in the renal biopsy. So we have 3 different disorders producing the same symptoms with different findings in the renal biopsy. So after delivering the content, this is the most important part for this presentation. This is the clinical case that we use for the different disorders. It's a 32-year-old male presenting with hemoptysis. On the physical exam, we have pulmonary findings here, and the laboratory tests show increase in the creatinine, hematuria, and red cell counts. So usually here, I ask the students about the findings. What do you think are the main findings here? And usually we have the positive findings are hemoptysis, pulmonary findings in the clinical exam, increasing the creatinine, and hematuria. These symptoms will lead to two different disorders, a pulmonary bleeding, because hemoptysis and pulmonary findings, and renal failure, or glomerulonephritis. And we have three different possibilities. Type 1, or Goodpasture syndrome. Type 2, mediated by immune complexes like systemic lupus, and finally, ANCA-associated vasculitis. So here we discuss the same case with three different possibilities. And the next step is the clinical scenario 1. So if you are following this patient in the emergency room or the intensive care unit, and you receive the different test, if the patient is having anti-GVN antibodies, and the renal biopsy shows linear deposition, which is the most likely diagnosis? So usually they are able to make the diagnosis like anti-GVN syndrome or type 1. But we are having the same case with a different serological marker, anti-nuclear antibody. The renal biopsy shows a different finding, granular deposition. So which is the most likely diagnosis? And we discuss with the students 10 or 20 seconds of discussion to arrive to the SLE diagnosis. And what about the patient? What if the patient presents with ANCA and absence of immunoglobulin in immunofluorescence, which is the most likely diagnosis, and is finally an ANCA-associated vasculitis. So we are using the same case with three different clinical scenarios based on the serological markers and the renal biopsy findings. And by the way, this is the PBL case for that. So we established the link between the traditional lecture or the lecture here and the PBL that they are learning. It's a patient with crescent and ANCA-associated vasculitis, microscopic polyangiitis. So that's the first case in renal pathology, and then we use repetition. So flowchart, concept maps. For example, in the renal biopsy lecture, I have this concept map 4 or 5 times in the presentation. So here we are in nephritic, presenting here, 3 different options, GBM, immune complex, ANCA, with the 3 different markers. The students do have this flow chart. They can modify, they can update. So that's a good strategy also to remember the different types of disorders. That's the case for renal pathology. So the second example is a different approach. For example, here we have a case on type 2 diabetes, when we can have one clinical case or one question with multiple questions regarding this clinical presentation. For example, here we have a 55-year-old woman with family history of type 2 diabetes, with obesity and laboratory tests showing fasting plasma glucose of 160 milligrams. So here we have the same case, and the first question for the students is this patient meeting the diagnostic criteria for the diabetes? Because here we have some findings, but most important point here is to distinguish between pre-diabetes and diabetes. So we can discuss the table here, and we see that the patient is having diabetes because fasting glucose is high and the glycosylated hemoglobin is high. So yes, the answer is yes, the patient is having as meeting the diagnostic criteria for diabetes. By using the same clinical case, we can make a different question. Given the epidemiology, which type of diabetes is most likely to be seen in this patient? And we already covered type 1 and type 2 diabetes. So they are able to answer that this patient probably is having type 2 diabetes. Then we can ask about the pathological aspects. So what is the main finding or the underlying pathology? And they can answer the insulin resistance in peripheral tissues. And you can also make challenge why the patient is not having an autoimmune destruction. And usually the students can answer that this destruction is the main mechanism for type 1 diabetes. So we are establishing the difference all the time. Then if we have a patient with type 2 diabetes, what do we expect in the biopsy, in the pancreatic biopsy? And we have options here. They can answer the amyloid deposits and always showing the figures or pictures to remember the pathology and which type of acute complication. So we have 5 questions just based in one single case. Then we can move to the pharmacology aspects. So which of the following is the most appropriate pharmacological therapy? And here metformin is the first option, and we can establish more questions regarding, for example, complication. What if the patient presents an adverse reaction to metformin? What if the patient is having contraindications to metformin? Or what if the patient is presenting with glycosylated hemoglobin of 11? Is the patient requires insulin or not? So we can establish different challenges at the beginning. Or we can move to more chronic complications using the same case or a different one with different manifestations here. For example, a patient with neurological symptoms. But here we think about peripheral neuropathy related to diabetes, but we are asking about the pathophysiological aspects. So we can review once again the main mechanisms of non-enzymatic glycosylation, osmotic damage, or endothelial dysfunction. So, and then after reviewing the different mechanisms, we can answer the question like B, for example, which is the most important mechanism for patients with peripheral neuropathy. Another important strategy is using the same case with a timeline progression. So, for example, the same patient, but 3 years later, the patient presents to the nephrology clinic with a different complication, with proteinuria. So if we take a renal biopsy, we think about renal or diabetic nephropathy. What do we expect in the biopsy? And the right answer is C, the nodules here that are extremely characteristic. And this is a very ideal point for the board exam. So we are using the same case to evaluate diagnosis, complications, treatment, and physiopathological aspects. The third example is a different one because this is specific for viral hepatitis. So we use also the different chapters and questions that they can answer, for example, in Robbins review of pathology, to have this knowledge. And for viral hepatitis, this is the usual presentation, the traditional presentation, talking about the different infections, hepatitis A, B, C, D, and E, different infections that can also affect the liver. And the clinical syndromes, anytime showing some patients are asymptomatic, some patients can have complications, some patients can have even liver failure. And here in red, we have an important complication that is very high yield in the boards. For example, hepatitis E in pregnant women is extremely complicated. So we established the link between complications, different clinical patterns, and also the board exam. Chronic hepatitis, hepatitis C is the most important for more than 6 months. And then it's just showing how the traditional lecture is, showing hepatitis A, B with the clinical presentation, diagnosis. And another important strategy for lecture is to make questions. what is the structure of hepatitis B? And here we have the infection, the hepatitis B virus, with different markers that are important for the diagnosis. So we can establish this kind of interaction with these students. Hepatitis C is is the most common cause of chronic hepatitis. Then we talk about hepatitis D and E. Obviously, we explain every single content here. Then summary of the most important information. And this table shows the differential between A, B, C, D, and E with the mode of transmission, complications, chronicity. So we are repeating the information basically. And some tips for the USMLE that I give to the students, because if you have a question regarding hepatitis, it's an acute patient with acute symptoms, probably is going to be hepatitis A and E. Chronic, it's going to be more like hepatitis C, and so on. But at the same time, we have to evaluate the difference, like autoimmune hepatitis, for example, which is an immune reaction related to inflammation and liver damage. Here we have the genetic components for autoimmune hepatitis, which is DR3 and DR4. And these genetic components are the same for type 1 diabetes. And usually in the curriculum, we cover liver pathology 3 or 4 weeks after diabetes. So it's really good to incorporate and remember that the genetic factors, for example, here are the same as type 1 diabetes to establish a connection between the different disorders. So that's the idea here. So after covering all the different infections, we have the clinical scenario. And this is the same case for all the different diagnoses. It's a 32-year-old woman presenting with acute symptoms for 3 weeks with dark urine, jaundice, and right upper quadrant pain. We have increase in the AST and ALT, so probably acute hepatitis. But the symptoms improve in 3 weeks. So I asked the students about the positive findings. So acute symptoms, hepatitis with increase in AST, ALT, and the outcome without complications. So what are the main possibilities? So usually they answer this. Autoimmune acute hepatitis with hepatitis A, B, and E as the options, and then the laboratory test. So if you are following this patient in the ER or in the hospital, you receive this panel. What do you think about the diagnosis? So here we only have one positive, the hepatitis A positive. So that's the final diagnosis. And I use the same strategy for hepatitis B, clinical case 3 weeks, but 8 years ago. So the same symptoms, acute symptoms, but 8 years ago. And right now we are having chronic complications. So once again, the highlights, the chronic possibilities, and the profile. So here we have a diagnosis of hepatitis B with active infection. And once again, we try to remember the diagnosis here, the different moments or stages of infection like acute, chronic, or immunization. So we are here in the chronic context because the panel is positive for chronic. So it's just showing different examples using the same clinical presentation. Once again, the same case, but with some slightly changes here, like a tattoo artist, for example, with a chronic progression. So we have an acute symptom with chronic progression. So here we are in a different context, more like chronic possibility, hepatitis B, C, D. This is the panel, which is positive for hepatitis C. So that's the diagnosis. But we also have an antibody against surface antigen for hepatitis B. So I asked the question, what does the surface antigen antibody mean? They usually are able to answer that the patient is vaccinated against hepatitis B for use immunization, like this one. The only marker is the surface antigen antibody positive, which is protective due to the vaccination. and the same age, with the same symptoms, but with some epidemiological changes, like a pregnant woman living in India, which is extremely important for hepatitis E and complications. And this type of question is always on the board exam. But probably this is the most challenging question. Here we have the same patient with the same symptoms with hepatitis. The possibilities are the same, hepatitis A, B, and E, but the serological panel is negative. So we rule out infections, at least the most common. So what are the possibilities? So we talk about the differential, like non-alcoholic fatty liver disease or different infections like CMV, but we don't have a history of transplant or the patient is not immune suppressed. We also have the possibility of toxicity by any medication or autoimmunity. Then we ask for the liver biopsy and the different panels, and here we have the main findings for autoimmune hepatitis. So they are able to make the diagnosis using this kind of strategy. The serological panel, which is negative for viral infections, ruling out the different possibilities, and then the findings in the liver biopsy to make the diagnosis of autoimmunity. And this is the last example. So this is one case showing clinical presentation and also the differential. This is the first slide on the rheumatoid arthritis presentation. So we talk about a 30-year-old female having several years of joint pain and swelling with morning stiffness, with physical exams showing deformities on the PIPs and MCPs. The question is regarding the serological aspect. Which of the following is the most important or the most helpful to rule in a diagnosis of rheumatoid arthritis? So at this time, the students probably do not know the answer because we have many options here, rheumatoid factor, anti-nuclear antibodies. But then, and before to cover the clinical case, we can take a closer look for the differential, especially for this type of patients with acute versus chronic presentation. We can answer the question regarding onset of symptoms. Is the patient having an acute presentation or chronic presentation? Here we have the several years, so it's more chronic because it's more than 6 weeks. The number of joints is polyarticular, the PIPs, the MCPs, the time of day, the pain is worse in the morning with morning stiffness, meaning inflammation. So probably after the discussion, students are able to identify the rheumatoid arthritis diagnosis. Then the traditional content, delivering the content with definition, pathogenesis of the disorder, the autoantibodies that are useful for rheumatoid arthritis. Here, basically, we cover 2 different autoantibodies, the citrullinated peptide, which is the most specific for rheumatoid arthritis, and rheumatoid factor. The morphology, clinical features, X-ray findings, and finally treatment. Like here, for example, methotrexate is the most commonly used, and we can discuss about the different options of treatment. And this is the, after the discussion, we make it here the answer. Anti-citrullinated peptide antibody is the most specific for rheumatoid. So that's the right answer. But we can also discuss the increment. Rheumatoid factor is also useful for rheumatoid arthritis, but is less specific because we can see rheumatoid factor in different disorders like systemic lupus or even healthy people. Or the anti-nuclear antibody, SLE, for example, and smooth muscle is a marker for autoimmune hepatitis that we already covered in the previous example. So in that case, we established links between all the options. So this is the final slide conclusion. So the first point or the first step to make lectures with clinical cases or questions is to identify the learning objectives, trying to integrate with the pathophysiological aspects, diagnosis, clinical treatment, clinical manifestations, and treatment. The second step is selecting and developing cases. Here, cases have to be realistic, relevant, with clear clinical scenarios that match the knowledge level. Structuring the session with clinical presentation, analysis of the questions to incorporate more knowledge, summarize key points, and provide rationale for incorrect answer. Facilitating the session with participation, challenge, manage time, use certain questions to stimulate discussions. What about this possible? What if the patient is having a different option or different manifestation, or if the serological marker is negative, what do you think? So that kind of questions. And finally, feedback with the explanation, summary, and reinforce key learning points. Every time we try to reinforce and to put, once again, the content to obtain the best outcome. So these are the 5 steps that you already have in the summary. And that's it. I don't know if you have any questions. Be happy to answer. Thank you. Thank you, Dr. Lee.
So Gabriel, when you start a session from the very beginning, it's a brand new one, how long does it take you to make one?
It's a good question. It takes a lot of time. Yeah, depending on the lecture. For example, for renal pathology or liver pathology, that are the big ones. I start to read different resources. So the first approach is to review drawings, then different resources, pathoma, 3 or 4 resources. And always you see a similar content some are more, so some are deeper or some are more, the content is light, but the final, all the structure is pretty much the same. Then I used to draw in a big paper or the whiteboard, like the clinical cases, for example, in renal pathology, nephrotic, tubal interstitial, and cancer. So at least we have to cover 4 clinical cases in the session. And then it can take 2 weeks to prepare one lecture like that, renal pathology, putting the figures, modifying the clinical case, but it takes time. Right now is easier because the backbone is already established, so it's just trying to update or modify different.
So how long is it, once you build one, it takes 2 weeks, that hurts, right? But if you're just giving it again the next year, how long does it take to update it?
Say at least 3 or 4 days or almost 1 week,
Okay.
to update. Because, depending on the time, sometimes you have a lot of content and you spend more than, 5 or 10 minutes more, so you have to modify the presentation. So you have to delete some slides or to incorporate a new one. So it takes, I think, 1 week for, the big ones, liver, renal, heart failure, vasculitis.
Thank you.
Oh, thank you.
We have a hand raised on WebEx, so Dr. Tishikao.
So thanks, Gabriel, for that presentation. Really nice. I have a couple of questions. One is, you talked about how you are incorporating these clinical cases, and you talked about, especially in year 2, how you build on the knowledge that they've already gotten in year 1, and so you can actually use that. But I'm wondering, and I think you kind of alluded to this in your talk, where do you insert these clinical cases in your lecture? How much time do you spend building on the basics of the pathology and just giving didactic information before you insert the clinical case? Because I could see two different ways here. We can either start with the clinical case and then back up to the pathology and explain it from that way, or we can give them a foundation of the pathology and then insert the clinical case. Which of those options works best for you and which do you use?
Yeah, thank you. Thank you for the question. Yeah, I think one important point here for this kind of presentation is also to be able to adapt to the model, because sometimes it's better to incorporate the clinical cases at the very beginning as the first slide. For example, for rheumatic diseases, we have one case and we can discuss the differential of the rheumatic disorders just in one case regarding the number of joints, the time, and so on. But sometimes it's better to put the case at the end of the presentation. But for me, the best way is starting with the clinical case, even if the students are not able to get the answer, and then describing the main findings of the clinical presentation, and then delivering the content for pathology or pharmacology, and then explaining once again the question, giving the answer, or the students are able to get the answer and the incorrect options, the rationale for the incorrect options. So I think for me, anytime that is possible for me is start with the clinical case or the question. For example, for pancreatitis. So acute pancreatitis, so I put a clinical case with acute symptoms. And then if we move to chronic pancreatitis, a different case with chronic presentation. So like a case for every single chapter of the talk. But I think at the beginning works the best for me. But it's every faculty has its own model. So, but I really find that this is the best way to start and to engage the students, because if you start with the clinical presentation, probably they are more engaged they want to know what is next, what is the next step.
I think from a student perspective, it helps build a story to
That's right.
follow. And sometimes when you have that story, it's a lot easier to make the
The
connections.
connection, that's right.
And question from Dr. Bodmeyer.
Yeah, thank you very much, Gabriel, for that awesome talk. One of the things that we get and that you alluded to at the very beginning is we can't cover everything in our resource sessions. So what we're touching upon is more of the difficult learning objectives that our students have. Have you ever kind of shared as a summary, like, here's what we've covered, but here are some things that you need to use for self-directed learning, so that it gives our students a kind of where to go from here type summary? What are your thoughts on that? Because that's something I was considering even going into with some of my own resource sessions.
That's right. It's a very good question and very difficult answer, because the time is the main limit. I think for example, for renal pathology, you have 2 hours to cover more than 100 diseases. It's impossible in 2 hours. So you have a list of disorders, and you can start in the traditional lectures covering the first one is this, the second, the third one, the fourth, and you can cover 50 or 60 pathologies in 2 hours. But at the end of the lecture, the knowledge is very low. So I will sacrifice the time, 5 or 10 minutes of the lecture, trying to describe a clinical case or clinical history that can make more open to discussion and to the differential. So if we don't have the time to cover every single disease, we usually put the different disorders in the list at the end, or the keywords also at the beginning. So you have to cover these different pathologies, but today we are just covering the essential ones, the most important for the board's exams and for your clinical knowledge. But it's very difficult. And even if we include clinical cases, we have to keep in the time. We have the same time to deliver. So strategies, for example, using concept maps and the list of the keywords and the different disorders is very useful for the self-directed learning for the students.
It looks like Dr. Tishkau has another question or comment. So.
Yeah, thanks, Andrew. And I'm sort of interested in the answer to this question from both the instructor's perspective and from Jamina, from the student's perspective on this. So, and this gets back to something you were just mentioning, and that is the use of concept maps. So I wonder, you showed in one of your examples how you actually incorporate the concept map into the lecture itself. I'm wondering, how frequent do you do that? Are there certain topics that lend themselves to that a little bit better than others? And then also from the student's perspective, how is that received? Do you find those concept maps embedded within lectures to be helpful to sort of guide your thinking and decision-making process along the way? Or exactly how do you use those in the lecture context?
Do you want to answer?
I think one of the things that Dr. Tobon, if I remember well from second year, did is that this concept map wasn't just like on one slide. We would discuss a case and go through the relevant pathophysiology and whether we go into pharmacology too. And then that concept map would come up again. For me, that process of multiple exposure and like making connection back to something we just talked about, I found super helpful because I'm able to look at all the different angles this material or this topic can present, and also seeing it in the big picture of the concept map.
Yeah, the concept map or the flow charts are very useful to integrate difficult contents. For example, we talk about renal or liver or CNS infections, for example, that many diagnostic possibilities are in the content. We can use like a good strategy. For example, for renal pathology, I try to separate the most important nephritic and nephrotic. And in the lecture, I have even the poster, the printed poster in the whiteboard. So I can establish connection during the talk with the different types because, for example, in that particular case, the students have to be able to separate nephritic and nephrotic as the first step. And then they can go in deep in the different etiology. So having the concept map is very helpful for that kind of sessions. Not all the sessions are really good to work with the concept map or the flow chart. Some are more difficult to work with, but definitely if I have to make for big sessions, like big content, I use the concept map in the presentation and several times. If we cover, for example, nephritic, so the concept map showing where nephritic is, then nephrotic where nephrotic is, and the different options, and going back and forward, as Nina said. Yeah, multiple exposures can be very helpful for the students, especially for retention at the end of the session.
Any other questions? I just have a quick question. So how long have you implemented this case-based resource sessions?
Yeah, I have experience in teaching for a long time, but at the beginning, I did the traditional lectures. I mean, conventional one. But at the same time, I conducted a small group discussion, and I found that having the clinical case in the small groups with these possibilities of differential, or what if the patient presents with a different manifestation, was more useful to retention. So then I tried to incorporate the clinical cases in the presentation, about, let's say, 10 years ago.
So did you actually feel the difference from the students? The change?
That depends on the number of students also,
Oh.
yeah. Because even if you, that's a limitation because you're still in the big rooms with 20, 30 students. And you see that some of the students are very engaged, some of the students are not engaged. But I don't think it's resistance, it's more like the participation is always like that. Some students are very engaged, participating all the time, even if they are wrong, they can feel safe to answer the question. So I don't see any resistance right now, especially here. I mean, the students are very engaged. So I'm very, very happy with that. I mean, the students participate in the sessions with Dr. S, with the Slido. The students are very, very engaged.
Yeah.
Thank you.
Any other questions? Thank you again
Thank you.
for your
Thank you so
great
much.
session today.
Thank you.
And
Thank you
let's
for the
give him
invitation.
another round of applause
Thank you.
for the presentation. Yeah.
Andrew, how many people are logged in? Can you tell me the number?
Oh, on WebEx?
Yeah.
We have a 1, 2, 3, 4, 4. Yeah. Okay, and I hope you all enjoyed the workshop today, and I hope it was helpful for you. One way to appreciate to our speaker is to provide a constructive feedback. Crystal White will send you an email about the evaluation of the discussion. Please do the evaluation. And next session is also in September as well. In September 19th at noon in the Lincoln Conference Room, Sarah Stout, Deputy Director of the Patient Experience Team, will lead the workshop about the patient experience, how their perspective is different from ours. So that's our next workshop. So thank you all for joining today's workshop. Thank you very much. Thank you.
Thank you.